Our next speaker is Sara Traigle van Geertruyden, and she serves as the Executive Director of the Partnership for Improving Patient Care, or PIPC. AAKP and PIPC have a very strong relationship, and we share an agenda regarding patient access to new innovations, especially biologics, that may help patients that are in need, especially those who suffer from rare diseases. In the terms of rare kidney diseases, AAKP is very optimistic about innovations that are coming, especially in the field of biologics that might help kidney patients that have genetic diseases or kidney patients that suffer from diabetic kidney disease or issues like anemia. In particular, there's a policy issue that PIPC and AAKP feel very strong about, and that is the application of what they call quality adjusted life year data to the approval or to the discussion of new drugs and innovations that are in the marketplace. And basically, it goes like this. There are some organizations that take a look at the approvals of new drugs, and they take a look at them only through the lens of an economic analysis, meaning, are they too costly, or will only a certain portion of the patient population benefit from this, and at what cost? We actually view these issues differently. We're in the business of trying to save lives and align quality treatment to patients so they can pursue their aspirations. So in discussions at the public policy level about what drugs are approved and what drugs are not approved, AAKP has made a very clear and strong voice for over 50 years, which is this. We will work with those who have the courage and innovation and resources to bring products to market safely that help benefit patients, improve their lives, and extend their lives. And when discussions happen where the patient perspective is not represented, then we work with a lot of different allies, our medical professional societies like ASN and RPA, and we also work with groups like PIPC, who bring the voice of disability patient organizations and patients that are in a tough spot, like many of our patients at AAKP, so that we have a unified voice on Capitol Hill and in the policy process to make certain that you, as a patient, still have ongoing access to the drugs that you know and new drugs that are coming into the marketplace. We believe that patient consumers deserve an equal voice at the table as much as a health econometrics expert. So without further ado, our friend Sara.
Hi, thank you. My name is Sara van Geertruyden. I want to thank AAKP for having me again this year to present. It really is an honor. So first I want to talk a little bit about who PIPC is and why we're here. We're here today to talk about potential barriers to innovation and greater patient choice. As you may remember, last year I was here talking about PCORI, the Patient-Centered Outcomes Research Institute. And this conversation is very much an extension of that, talking about value assessment. As some of you may know, Tony Coelho is the chairman of the Partnership to Improve Patient Care. He also was the author of the Americans with Disabilities Act, and throughout his life has been an avid disability advocate. As you may know, the mantra for the disability community has always been nothing about us without us. And when I say it's for the disability community, it's really become a mantra, I think, that goes throughout the disability patient and community of older adults that's served by programs like Medicare and Medicaid. Tony is a person with epilepsy and therefore has a tremendous amount of insight on these issues and a passion for disability rights. PIPC, the Partnership to Improve Patient Care, which Tony chairs and I'm the executive director, we began as a coalition that advocated for the creation of PCORI, the Patient-Centered Outcomes Research Institute, because we believed so strongly that patients deserved and needed to have a seat at the table in developing research. And now we have kind of really extended that mission into making sure that how we value treatments is also patient-centered, because we know that no patient is average. So just a little bit about our current priorities. As many of you know, this crisis has really taken its toll on the broader disability community. We've been very focused on how life years and quality of life calculations are being used to ration care based on disability during this COVID-19 crisis. We've also been continuing to be active on advancing patient-centered research and patient-centered value assessment, and trying to make sure that patients and people with disabilities are at the table when we are talking about policies that will affect them. So the issue that we would like to educate on today is the quality adjusted life year. Some of you may or may not have heard of this metric, but it is a metric that underpins value assessment. And when I say value assessment, I mean how we assess the value of new treatments that may be coming to market. Our concern is that this metric called the quality adjusted life year discriminates against people with disabilities and serious chronic conditions by lowering the value of their lives. If you look at this chart, for instance, a death would be a 0, perfect health would be a 1. Somewhere in the middle, having looked at this just recently, a person with chronic kidney disease would actually fall somewhere between a 0.5 and a 0.7. When you think about the incremental improvement in quality of life that emanates from a treatment, the quality adjusted life year tries to measure whether you've gone from a 0.3 to a 0.5 or a 0.4 to a 0.7. If, as a patient, your quality of life is considered to max out at, say, a 0.7, then the incremental improvement in your quality of life is going to be smaller than someone who may, for instance, achieve a 1. So this is a metric that just fundamentally and inherently devalues the lives of people with disabilities and devalues the treatments that are developed for them. So in this slide, we want to talk a little bit about the challenges of the quality adjusted life year. When we're looking at population survey models, the non-disabled population is going to systemically look better than the disabled population. So for instance, a majority of people in the broad American public would say that they would rather live with HIV than be blind. The problem with that is that they're not surveying people who actually live with these conditions. Another example is that inflammatory arthritis might be seen based on these population surveys as worse than death. But what we also see is that under models where people with disabilities are self-reporting their quality of life, and when I say people with disabilities, I am including patients who tend to be covered as under disability laws, well-supported people with disabilities report high levels of quality of life due to their access to adequate support. Why? Because their treatments are working and they are supported. What happens in the quality adjusted life year metric, though, is that we end up exacerbating disparities by relying on randomized clinical trials that don't necessarily reflect subpopulations who, as we all know, are poorly reflected in the research. The organization that tends to use these types of quality-based value assessments, the one that we think about the most is the Institute for Clinical and Economic Review, ICER. So what does ICER do? ICER conducts cost-effectiveness analyses of new drugs. For everyone on this event, you probably are aware that ICER is currently in the process of developing a scoping document on assessing drugs for anemia and kidney disease. They're also advancing a model for assessing COVID-19 treatments. ICER is not a part of the government, though. They're not affiliated with the FDA. They're not affiliated with CMS. But they do these value assessments to inform primarily private insurers. So we've continued to provide comments to ICER reflecting the flaws in their model in hopes that they'll change. First and foremost, we've expressed concerns that they continue to rely on the discriminatory QALY method, the cost per QALY. They also have a history of failing to meaningfully engage expert stakeholders by not giving them a role in the voting process when they vote on what is the value of this treatment. They also fail often to consider outcomes that matter to patients and people with disabilities, such as critical elements like caregiving and the cost of caregiving. Their assessments also tend to be done very early when a treatment has just come out and there's very little data on those treatments as compared to others. There's also a tremendous lack of transparency in their model in terms of how they get to the conclusions that they get to, such that they're very difficult to replicate and certainly are not peer-reviewed. Of late, we've been even more cognizant of how their methods exacerbate disparities. If you look at randomized clinical trials, as I mentioned before, they just don't reflect subpopulations. When you're using a population perspective, i.e. looking at averages, You're not going to then be taking into large consideration people's genetic background, demographics, risk, and comorbidities. So when you think about the weights of health states for translation into QALYs, they are actually mostly undertaken in primarily white populations. And the domains that make up quality of life tools were actually constructed by a small group of elderly white men 20 years ago in Switzerland. So ICER has also come up with a metric that they're calling the equal value life year gained. And I'm just going to touch on this briefly, but the point of that is that it really doesn't fix the problem. While it adjusts for the life years component of quality adjusted life years, how many life years a person has left is taken out of the equation, but it only partially mitigates that life extension problem, and of course would have to be used by insurers to be meaningful. It still offers, though, payers a means of refusing access to an effective and beneficial treatment. It really doesn't address the underlying value and the quality of life improvements that are presented in a new product, especially because it ignores clinical knowledge, which is the kind of knowledge that clinicians will have that isn't necessarily reflected in the research data. Quality-based systems, as you know, are just less effective than condition-specific means of assessment, and I think that's our biggest concern. So this slide reflects that we just can't look at averages. Every person is different, and the impact and the implication of a treatment for an individual is typically not related to the average. The key takeaway here is that different people respond differently to the same drugs, and also that for many conditions, such disparities are reflected in clinical knowledge, but are not yet reflected in research literature. And yet this organization called ICER has evolved. It was founded in 2006. It later was reflected in a proposed demonstration project that CMS had put out back in March of 2016. That demonstration project never moved forward because of the advocacy of the patient and disability communities against it because of its reference to quality adjusted life years. Then later, ICER did successfully engage in a partnership with the Veterans Affairs Department in their Veterans Health System. So now ICER is being used to help inform their formularies. Then in 2017 of October, ICER received $13.9 million from the Arnold Foundation, which is now called Arnold Ventures. The Arnold Foundation, or Arnold Ventures now, has been largely supporting ICER's work. Then in 2018, ICER began a collaboration with New York's Drug Utilization Review Board. And in fact, they just recently invited ICER to one of their meetings as they reviewed a drug for spinal muscular atrophy. And then lastly, there was a proposal by CVS Caremark to reference ICER and to benchmark a benefit design on $100,000 per QALY. So anything that was above that number would not be covered in their benefit package for certain employer clients. Thankfully, CVS has ceased marketing that product because of engagement from both the Partnership to Improve Patient Care and other groups, which we're relieved about, but it still, I think, highlights what a threat this is. As background, the quality adjusted life year has historically been rejected by policymakers, and in fact, the Affordable Care Act prohibited PCORI from using the cost per QALY to determine effectiveness and further restricted its use in Medicare to determine coverage, reimbursement, and incentive programs. Even further back, and keeping in mind that in 1990, the Americans with Disabilities Act was passed. So 2 years later, in 1992, HHS rejected Oregon's prioritized list of covered services for Medicaid, citing the potential for violating the ADA because they intended to use the QALY and a cost-effectiveness metric to determine whether they would or would not cover. I like this slide because it outlines some of the comments that were made by the HHS secretary back when Oregon's Medicaid waiver was rejected and sent back. It makes it very, very clear that the main concern that HHS had in doing that was that quality adjusted life years would lead to a benefit design that was discriminatory. So you may be asking why you should care about these issues. Primarily, and this slide is intended to represent what would happen if we were to use a quality-based benchmark for what we would cover in Medicare or in Medicaid. So in Medicare Part B, which is very relevant now, you will see that for rheumatoid arthritis, multiple sclerosis, small cell lung cancer, multiple myeloma, there would be significant impacts to people who would be forced to take an alternative treatment. And you see the same dynamic that would happen under Medicaid for conditions like psoriasis, multiple myeloma, small cell lung cancer, MS, and rheumatoid arthritis. People would be forced to try to take a different product if we were to rely on a cost effectiveness analysis based on QALYs to what we will or will not cover. In other countries, they do rely on QALYs to determine what they will or will not cover. What we see internationally is not good. So if you think about cancers, the 5-year survival rates are higher in the US than in Canada, France, Germany, Italy, Japan, and the UK. There are fewer options for patients in those countries and slower access to medications. So while a medication may come out 1 year, patients in those countries may not see access to it for 2 years or so. We're seeing this a lot lately, particularly for disabling conditions like cystic fibrosis, where there's been tremendous drug development. What's caused great concern too is that while there is a ban on the use of QALYs in Medicare, we're seeing states take action to reference ICER and QALY-based assessments. That's happening because the administration put out a budget that invited states to make drug coverage decisions that meet state needs, indicating that they would accept limited formularies. The good news is that states like Oklahoma have actually, the state of Oklahoma did pass a QALY ban. So they have actually said in response to their Drug Utilization Review Board using ICER's studies that they will no longer allow that. So we're very excited about that, and hopefully other states will replicate that model. Unfortunately, New York has already endorsed using QALYs and ICER. Their budget went in a different direction, and they actually endorsed the use of third parties like ICER. Massachusetts has been considering using QALYs and ICER. We actually just learned that in Massachusetts, they have contracted with ICER to help them come up with a value framework that will be used by their Health Policy Commission. In California, a few years ago, their Legislative Analyst Office also recommended that the legislature consider a model such as New York's. And they also had an executive idea that was circulated last year around referencing foreign prices, which are based on quality adjusted life years. There was also a waiver application submitted to CMS by the state of Tennessee that would have used cost effectiveness to limit formularies, sort of inviting a group like ICER to come in and be the arbiter for what they will or will not cover. So what we're most concerned about now is what's happening at the federal level. You may have seen that on July 24th, the president proposed an executive order that he's calling a most favored nation executive order. What it would do is to reference the lowest price for Medicare Part B drugs in other countries, regardless of whether it was based on QALYs. This is an executive order that builds on the president's earlier proposal from 2018 to use an international price index in Medicare to price drugs, without consideration, though, for how those prices are established and what the implications for those prices may be on patient access to care. What we know is that in other countries, their access to treatments is very much delayed if they get access at all to new treatments. There's a significant concern, as you can imagine, then, about using a discriminatory metric in the United States that's similar to what those other countries are using. Unfortunately, too, there was legislation passed in the House of Representatives called H.R. 3 that would also reference international prices from 6 countries and authorizes use of studies from groups like ICER to determine comparative effectiveness of treatments. We're genuinely concerned about this proposal as well, although thankfully that one did not advance to the Senate. It is our hope in working with AAKP and with all of you to be able to amplify these concerns to help make sure that advocates both at the state and the federal level understand the challenges that QALYs impose as we think about how we're going to build a patient-centered health system. One thing that I can tell you is that qualities are not patient-centered, and their use in public policy can have devastating implications for how people access care. So I'm really excited to be here, and I want to thank AAKP for giving us this opportunity to talk about these really important issues. I know it gets wonky very quickly, and but we really do appreciate all of you.
Thank you very much, Sarah. We look forward to continued collaboration with PIPC, and we appreciate the hard work you're doing to raise the voice of those in the disabled community and kidney patients on Capitol Hill. Consider AAKP a strong ally, and we look forward to working with you.